But last but not least, we've got Dr. Mark Murphy on. Mark Murphy is a DSM veteran of 25 years. He is the head of clinical faculty for Prosomnus and one of the pioneers in developing what we like to call precision oral appliance therapy. And probably my favorite part about his professional background is that he is not just an academic. He is a practicing dental sleep medicine provider. So when he talks about selling cases and helping patients get into therapy, he does it. He still practices, I believe, every week, and is helping patients, in the chair today. So, Mark, I think we're ready. If you want to get started.
Yeah, thank you, Chad. So every week, meaning maybe 45, 47 weeks a year, travel allowing, that kind of thing. And then I loved it. I got a little nervous when you said pioneer, because I'm thinking of who the real pioneers were, but pioneer precision oral appliance therapy, that I'm good with. That was fine. So yeah, I think that's appropriate. So thanks. It's great to have so many people wanting to come in and hear about this. And I'm certainly happy to share those slides. I'm happy to share all the slides I've got here tonight. Pretty much anything I've got that I do lecture or teach on, I'll send those out to anybody that ever not wants them. So we've got about an hour, and my biggest mistake I make so often is filling the entire hour. So I'm gonna try and get through this data so we can answer questions that pop up, because I always feel like I'm rushing on some of the questions, or I'm up till 9 o'clock, 9:30 at night trying to answer them. So we'll try and get to them a little faster. 8 steps to yes. 8 steps to yes. It's a play on words because there's 8 slides I use. And we can think of those as steps. We can think of those as constructs. We can do anything we want with those. But I use these 8 slides with, I want to say every patient. We send them to every patient for the consult. I review them with most of the patients. Certainly I review them with all of the patients who listen to this language and don't get concerned, but any of the patients that I need to close from a sales perspective, close into a test, and then certainly close and prep them to close into an appliance later on if their test comes back positive. Sometimes I don't have to go through as much of the depth with those, because probably half my patients, maybe 60%, come from sleep physicians, and they come in already diagnosed, already with a letter of medical necessity. They already have a prescription and they're ready to go. So for them, I ask them, I'll say, Denise sent you those slides. Did you have any questions about those? Did you get a chance to look at those? They kind of describe what we're going to do. And, so I talk through that a little bit. And some of them fire up a conversation, we have it, and some of them don't. But with any of the other patients, this is a great way to get more people to yes. No question about it. Outline for tonight, pretty simple. We're going to talk about the patient pathway, how patients process information in their decision-making process, how they move from unaware to aware to interested to coming to trust you to going ahead and saying yes. We're going to talk about what are the things that they're asking and thinking about in their mind that help them formulate a decision. And then we want to answer those questions. That's where the 8 slides come in. I want to answer all those questions for them before they ask them. I want those questions answered in their mind so that they know this is the right path. They know that I'm the right person. They know this is the right treatment. They know this is the right medically necessary treatment for them. And then listen to this next word, assumptive close. You're going to buy. That sounds like a salesy thing. So it's not very salesy, because when you think of salesy, we just bought a new car the other day, and it was very much transactional. Cars are very similar. You buy that same, we bought a new Chrysler Pacifica minivan, dead sexy car. My wife says it's got everything you ever wanted in a vehicle except for status, and I think she's right. But that car would be the same car at this dealership, that dealership, that dealership, this dealership, all the same car. Maybe a little different buying experience, maybe a little different service experience. Maybe they would take better care of me. But looking at the car, it's a commodity. It's a very expensive commodity. It's a $50,000 commodity, but it's a commodity nonetheless. So there's very much a transactional kind of relationship in that purchase. That's not the case in medicine. In medicine, a physician is talking to you, a PA is talking to you, a nurse practitioner, a caregiver, a provider is talking to you about your disease and what's medically necessary to treat that. Now, listen to that term, medically necessary. Do not remember that your typical medical office visit starts with, we're going to draw some blood today, take a chest x-ray, run some tests, we'll look at an x-ray, we'll do an MRI, whatever they say. And unlike dentistry, there's not a conversation about co-payments, deductibles, down payments, how much it's going to cost. Very different environment, because the assumption is you want to live. And this disease, hypertension, high cholesterol, cardiovascular disease, tumors, cancer, obstructive sleep apnea, can kill you. And so there's this assumption that you're going to treat this disease. It's not always true, but it is true so much more often in medicine than it is in dentistry, that I would argue we need to think like medicine when we talk about dental sleep medicine, talk about oral appliances, and have an assumptive close. The patient's pathway is not a mystery in medicine. It still has as many dental consultants as you can find on the dental side. I spent some time doing that years gone by with Mercer Advisors, the Pankey Institute, had a consulting company myself for a while, had a lot of fun with that, helping dentists be more successful at getting patients to say yes to dental treatment plans, an entirely different side of healthcare. In medicine, we have an insurance coverage. There's still going to be co-payments and out-of-pockets, but in dentistry, there is no insurance. In dentistry, there's no insurance, because insurance is defined as when a third party takes the risk for catastrophic loss. Nothing catastrophic, about $1,000 or $1,200 or $1,500. Certainly catastrophic when you get to thousands of dollars of treatment, surgery. I've had shoulder surgery done, $15,000, knees, $25,000. You can only imagine what really much more serious cardiovascular intervention costs. So this whole idea of insurance, third party picking up the cost, is very, very different in medicine for catastrophic expenses than it is in dentistry. And today, with trying to keep insurance costs down, sometimes people have larger deductibles. So sometimes it's still very much a cash discussion and a cash kind of conversation. Totally get that. Totally get that. And so that'll make sense as we go forward. But medicine has studied the patient pathway first in looking at chronic care management, cancer management, cardiovascular disease, because it required so much changing behavior. And how do they bring the patient into the healthcare process and invite them to change these and accept medically necessary treatments. And so they measure outcomes. They measure transition from point A to point B to point C as they travel through a pathway or a funnel in getting their treatment done. So we don't have to reinvent the wheel. We can just steal some of the best ideas from medicine, apply them to sleep in a dental practice, and maybe increase our success. I like it. The first conversational talk track, and you heard me use some of these terms a few minutes ago, is just to understand that the patient comes in with some level or not of awareness or not of what obstructive sleep apnea or snoring or their partner elbowing them or whatever that is. So our job is to walk them up this learning ladder from unaware of the disease state to aware, to maybe being able to personalize it for them so that they understand that they have a risk of maybe having this disease, that snoring often is sleep apnea, not 100% of the time, but often enough that we're concerned. Stop, bang, Epworth sleepiness scale. You know all the tools, not teaching those tonight. Enough of a connection at the awareness state that they become interested. I want them to lean into the conversation a little bit, because we're talking about them, or we're talking about their spouse. We're talking about their life, talking about their quality of life. Usually they can become interested. And then if you have a conversation with them that holds water, you can become trustworthy. And isn't that what we want to do with even our dental patients? We want them to become aware of the disease state, interested, come to believe or trust in us. And then we want them to ask that commitment statement. Well, Doc, what do you think we ought to do about that? You know, because I don't want to wear a CPAP. Well, I think you might be an oral appliance candidate. We want them to actually come to a place where they have this cognitive dissonance about treatment, where they ask us in a consultative way, hear this consultative selling concept. What do you think we ought to do? And that's a change in paradigm for patients, because a lot of patients come in very unaware. When patients are being screened in a dental practice. Now, when patients come in from my sleep physicians, very aware. They've had a conversation. The physician's already lit a fire under their butt and scared their bejeebers out of them. And they're coming in, script in one hand, sleep test in the other hand, they're ready to go. And they don't want to wear a CPAP, that's why they're here. But patients you're screening, conversations you're having there, it's going to be a little bit of a shift. And the big shift for most patients is from this idea of snoring to this very comprehensive comorbid environment that surrounds sleep apnea. So our conversation, our talk track, our examples can probably hit on 1 or 2 or 4 or 6 of the items that we see associated with sleep apnea for these patients, so that it creates a higher level of concern, not trying to scare them, concern, understanding, awareness, interest. And then when we talk to them in an objective way about information and data and science, and it doesn't mean we have to be science nerds. And we were talking before we started about a bunch of studies about high efficacy and precision oral appliances and cool stuff. And a couple of people were asking for those, and I'll send them out, no question. But it's we don't have to be nerdy and have them read a bunch of scientific articles about this, but we have to make them aware. And the messaging we have has to be based on science and facts and consistency with what they're being told in the medical model as well. And if we do that pretty well, then we start to move towards a conversation we can have with patients about understanding the difference and them feeling the difference, that they're in a medical model, when we're treating obstructive sleep apnea and not a dental practice. And that's important because patients have different ways that they move through the dental model than they do through the medical model. We and our patients have different behaviors that we have learned and that we have taught them, and that they have learned about their beliefs, their understandings, their perceptions, their paradigms about dentistry and dental insurance versus medical care and medical insurance. And so this whole idea of this conversation about money, I often say when I'm talking to practices that want to be more successful, one of the things I usually see in practices that are under indexing on the yeses that they get is they talk way too much about money, because we're used to doing that in dentistry. We're used to having to have those robust conversations about how much it's going to cost, how much it's going to be out of pocket, what the value of this is. And I'm not saying those aren't reasonable things to have in a conversation, but let them come from the patient asking, not from us telling, because it's all too often that we build these barriers. Chad, you look like you're ready to ask me a question, I can tell.
You're just on such a good one. I don't want to interrupt because you're so right. I actually got private messaged a question. I guarantee this will happen a couple more times tonight, but as a reminder, there's a question and answer section for these. Someone just asked you, you mentioned earlier, not talking to patients about the clinical stuff and the money. And then now you're getting into the how and the why. Beyond this, 1 hour webinar tonight, what do you have any recommendations on where to learn some soft skills or anything like that?
Yeah. We're going to have another webinar probably later in the year, and that'll be our topic.
There you go. All right. Dig it.
You got to go to Awaken to Sleep's webinar series featuring Murph Doggy Dog, and we'll cover that one off.
Sounds good.
So it's not something you're going to find in the mastery program with the DSM. It's not something you're going to find in a lot of the different courses. I know, Chad, I've lectured for you in some of your courses, your 1 day and your 2 days, and I know that is something you all talk about. You talk about how to talk to people about money. I love, Michael often says, now I'm not trying to scare them, but it will kind of scare them. But yeah, he's very eloquent saying, you're not trying to scare them, but one of the options is no treatment. And let me tell you what happens there. And that's scary as hell, right? So yeah, it's a little bit of that. So let me tell you a little anecdote. I talked about data earlier, so this will have some data in it, but this little story, I worked with a practice that was struggling. The practice was getting referrals from physicians. They were getting 60 referrals a month of patients coming in from this hospital group with a prescription in one hand and a sleep test in the other. High five, right? Awesome. Yeah. They were delivering 14 devices per month. 14.
Real quick, anyone in the audience would be interested in doing 14 appliances per month? There's a little raise hand icon. We're very interested. Make sure we got the right group tonight. Yeah, go ahead.
That's my December generally. That's working 1 day a week. I do about 14 in a month, about 3 a day, 4 weeks. So they knew that they had a problem. Clearly they did. They knew that they were doing something wrong. They had some suspicions, but they came to me and asked me, they said, Mark, you do a lot of this kind of stuff. And they were friends of mine. And so I flew out to see them. After having a lengthy conversation with both of the principals, flew out to see them, spent a day with them and their team, and then that evening delivered some news to them about what I thought they should do. And the next morning, we trained up the team on what to do. And the bottom line was this, and I'm going to shorten the story. For every single one of the patients, what they did is first a very complete and thorough examination and a consultation that lasted an hour. They explained all of the insurance, co-payments, deductibles for them, and explained to them that even though they had this explanation of all this information, they're going to have to wait for a pre-auth, and they can't guarantee that the insurance will pay what they think they're going to pay. They could still own this entire out-of-pocket amount. So they had every single patient sign a financial agreement that they would be responsible for the entire amount. This gets worse. And then they had them all make a deposit, put a down payment on before they would schedule their impression appointment. And I said, if you just took all that stuff away, you'd close more, a lot more. And they got very nervous. And I explained to them that what they had done is they had done typical dental thinking. They created an excellent system for the wrong thing. Management, great, doing things right. Leadership, poor. They weren't doing the right things. The right thing would be to help those patients get a device delivered in a timely fashion, knowing that maybe 1 or 2 or even 3 out of the 60 on an average month maybe skips town and doesn't pay their bill, but they'll get to a lot more devices. In the first month, when they eliminated all those financial conversations and barriers, they got very nervous, and they went from closing 22% to closing 80%.
Wow.
A month later, they went up to 90%, and they stayed high since. Now, just to do the math, forget what 16 devices is per month. It's already pretty good. This is a sleep-only practice, been around for a long time. But if you think about the difference between 14 and 54 per month, that is 40 devices a month on average. If they only got $2,500 a device for those 40 devices, it would be $100,000 a month in revenue. That'd be $1.2 million on the year. Hope you're following the bouncing ball. I'm doing the math quickly.
Yep.
And even if they had a 10%, which they wouldn't, but even if they had a 10%, they never did, not even close, that didn't pay. And they lost $120,000. They'd still have they'd still have $1,080, $1,080,000 left on the table that they wouldn't have had.
Mm-hmm.
So if that's the cost of doing business, that's cheaper than a marketing fee.
Yeah.
So they were very happy with the results by just getting the money talk out of the way on the medical side. And it's simple conversations, like when a patient says, well, how much is this going to cost? My team is trained, my wife and I, my team is trained. My group, my wife and I, my daughter, when she worked for me, we were trained to say, well, actually, Chad, it's covered under your medical insurance, which takes 8 out of the 10 questions and just swoops them under the rug. And for the other 2 patients who would say, well, listen, I have a $5,000 deductible. It's January. This whole thing's coming out of my pocket. What's going to cost me? And I'd say, well, don't worry. The good news is because you have Blue Cross, and I'm in network with Blue Cross, the maximum allowable benefit that Blue Cross allows is $2,456 here in Michigan. So that's the most it can cost you out of pocket. What I really said to the patient to comfort them was, don't worry, you think I'm going to rip you off and charge you too much money, but your insurance company sets a fee, not me, and you trust them. I didn't really say that to them, but that's what they heard. Okay, I digress. We're off that topic now, moving on. So
Cool.
If the patients aren't, and they are worried about money, don't think they're not worried about money, but they're going to figure out how to pay for it because it's medically necessary. It's not a crown that they want to look better, a tooth that's a little sensitive. It's a medically necessary treatment to save their life. But what the patients are worried about are 3 questions, and it's pretty simple. The 3 questions are, well, I hear you talking about this disease, and I hear some ramifications around that sound like it could be me. Stop bang, upward sleepiness scale. I'm over 50, I'm overweight, got high blood pressure, I snore. My wife has said I stopped breathing. Do I have this disease? Don't know. Got to get you tested. Is it serious? Well, hopefully I paint a picture for you with these 8 slides where you know it's life-threatening. Now, it's not life-threatening in that I think you're going to go home today and have a heart attack if you don't have an oral appliance in your mouth. But actually, if you're severe, that risk is 23 times more likely to have a heart attack while you're sleeping than the average person. The math, the data on the increase in the comorbidities and the shortness of life, or as I like to call it, not the shortness of life, the premature death for patients with obstructive sleep apnea. Think of the languaging we use. Don't say, this can shorten your life a little bit. The premature death that we see caused by obstructive sleep apnea is something that's very preventable, either with a CPAP, an oral appliance, certain surgical procedures like Inspire. I like to think of it that way. This premature death, because that's a lot more averse feeling than encouraging to say shortness of life. And then finally, well, if I do have this and it's serious, can you treat it? And so I always try to give them hope with that. And so in giving them hope, we do things with them, and I'll talk about that when we go through the slides, that helps them see that not only do we need a test so we can figure out if you have this, but it is really serious. And the hope is, yeah, we have a treatment. We have several treatments. Let's figure out which one is right for you. It might be CPAP, might be oral appliance, maybe it's surgery, maybe it's positional. There's a number of different things. Maybe it's weight loss if you're young enough. That'd be great. But these are the questions that medical research has found that patients with serious chronic conditions, chronic medical conditions, are asking when they're starting to assess hypertension, cholesterol, cardiovascular disease, tumors, cancer. Do I have this disease? Is it serious? Can you treat it? Can you get me back on a path? They're not asking how much does it cost, what's my copay, and how much goes towards my deductible. They're not asking how uncomfortable is the treatment. If they did, nobody would get Inspire, right? Because that's a surgical procedure and it's nothing easy. So you're probably asking yourself, like I am, how do we walk this patient down the road? Well, when we're thinking about how the patient has this, we're screening them. And so the screen gives us some information, and whether we use a stop bang, whether we use some sort of a questionnaire, the Epworth Sleepiness Scale. And when we talk about that, when we talk about screening patients and moving them into treatment, another discussion, by the way, we could talk about how we use that as almost an internal marketing tool to start a conversation, because it's really the stop bang that I want to utilize and say, you have 3 out of these 8 risk factors. That puts you at moderate risk. You have 4 or more. Doesn't matter whether it's 4 or 8. You have 4, 5, 6, or 7. You have 4 or more of these factors. That means you're 90, I say 90, it's actually 92% in the literature. You're 90% likely to have obstructive sleep apnea. But Chad, we still don't know if you have it or not unless we get you tested. So let's go ahead and get you tested. Presumptive close. Hear that? Assumptive close. Let's go ahead and get you tested. Not, would you like to get tested? Let me explain to you how much it's going to cost. Let's get you tested. That's the only way we can find out for sure. So let's ask and answer that question. A lot of practices, we use this sometimes with patients that don't have a bed partner that's reporting their snoring, is we'll have them use a tool like Snore Lab. I love it sometimes when a patient will say, well, my wife says I snore, but I don't think I snore. Really? You think they're going to lie about that? Well, for God's sakes, download Snore Lab on your phone and listen to yourself snore for a couple of nights, and I'm pretty sure you'll either believe your wife or you'll come get an oral appliance. These are things we can do to help the patient want to know, do they have this? Is it serious? Well, great question. Well, that's what my 8 slides, you can see them in the background there. Is it serious? I'm going to tell them what obstructive sleep apnea is. I'll go through these slides in a minute. Risk factors, comorbidities, treatment options, what we need to do to find out whether or not they have it all. But it's going to tell a very tenuous story about a shortened life, a premature death. And that this disease, although it doesn't really cause any primary diseases, maybe some arrhythmias, maybe drug-resistant hypertension, we can blame those primarily on obstructive sleep apnea. It doesn't cause diseases in and of itself, but it makes other diseases that patients tend to have way worse. Now we're looking at still maybe it has this influence on dementia. And so that may be a card we'll get to play as well. We do mention that sometimes in a conversation, this poor sleep, this lack of brain getting cleaned out leaves a lot of debris in there that sometimes seems to almost caramelize and create some of these demential changes. That's what they're starting to talk about in the literature. So it gives us this idea of, yeah, this is some serious shit. This is nothing to fool around with. This is really serious. And it's a silent killer, like so many other diseases are. You don't feel hypertension. You don't feel cardiovascular disease. You don't feel arteries closing 50, 60%. Not till they're 80 or 90%. Not till you have some angina pain going on your left arm. Do you say, yeah, I think I might have a heart problem. If you wait for pain as a warning sign, it's usually too late. So, and people will say sometimes, well, I don't feel any pain. Everything must be all right. No, the absence of pain does not mean okay. The absence of pain does not mean it's all right. The whole medical system is built on trying to find these markers, these indicators, these metrics that we can find about blood pressure, heart rate, weight, BMI, cholesterol, all these kinds of things, your AC1 or C1A, I forget what diabetics have to have, the prostate protein that we see. We do urinalysis. Why do they do all that stuff? They do all that stuff because those become really good ways for us to prevent premature death by managing those disease entities quite early. That's why so many of us get on those medications in our 40s and 50s. Can you treat it? Well, I usually have a slew of videos from a host of different patients, and I usually try to put up one that's similar to their situation or similar to their persona that they can see. And I say it doesn't always work, but it does work about 94% of the time for mild and moderate cases, drops down to about 80-85% for severe cases. But we're very, very effective. And it's a lot easier for patients to use this therapy than it is a CPAP. And so many patients say, I can never wear a CPAP. Almost everybody knows somebody with a CPAP, knows a story about a CPAP. So at least we don't have to teach them what a CPAP is. We often have to teach them what an oral appliance is. Is it treatable? Well, we want to give them hope. So somewhere in the consultation, somewhere, either while I'm talking about sleep apnea, somewhere while I'm going through the 8 slides, somewhere I'll say to them, well, do me a favor, lean your head back and make a snoring sound. And this is really a lot of fun in a room full of people. You know, we've got pushing 100 people in the room tonight, so that's great. So if we had 100 people in the room, we all lean back and made a snoring sound. On the count of 3, let's all do that. 1, 2, 3. Now stick your jaw forward. Feel the difference? Yeah, it was a lot harder to make that sound. Well, that's what we want to do for you. If I can find the right position to put your jaw forward a little bit like that, it can open your airway in the back. And if I can find the right spot and it opens it enough, we might be able to manage your apnea mechanically like that, rather than with pumping air down your tube. I'm giving them hope. Is it treatable? Usually. How often? 90%. I love quoting that statistic. Why? Because it doesn't always work. 1 out of 10 people non-responder, 1 out of 10 people maybe can't wear an oral appliance, doesn't like their jaw being forward, can't get used to it. 1 out of 10 mild to moderates, maybe 2 out of 10 severes. It's not a lot, but if you're one of those 2 out of 10 people and you're severe and you don't want to wear a CPAP and the oral appliance doesn't work, you'll be bummed. So I'm not going to overpromise and underdeliver. I'm going to say 90%, and I'm going to use that snore test to give them hope. So think of what we will have done with these 3 questions. Do I have it? No, got to get tested. You're definitely in high risk. We got to get you tested. Is it serious? Hell yes, it is. These slides are going to help illustrate that. And then finally, is it treatable? Well, I'm going to give you hope. That snore test is a beacon of hope for them that maybe it'll work. The bad news is, once in a while, somebody will lay their head back and make a snoring sound, stick their jaw forward, they'll make the same snoring sound. You go, well, that's not good. And I tell them that's not good, because if you can stick your jaw forward and still make that snoring sound, I'm afraid maybe it's still easy for you to collapse that airway. Would you still treat them? Sure. But maybe if they were sitting on the fence, I'd push them faster towards CPAP. It's not a scientific study. We don't have any data that shows that's a predictive test as to whether or not they can be treated with oral appliances. But anecdotally, I worry about it. That's why things like a CBCT scan looking at airway changes is really good information, but it doesn't tell us whether or not they'll be treatable. Acoustic pharyngometry, really cool, wonderful sales tool for patients to be able to see that. I love that. Predictive of whether or not the patient can be treated? No. Well, the snore test is the same way. It's just a lot less expensive than a CBCT scan. So those are the 3 questions. Those are the 3 kinds of answers that I try to look at to say, here's the answers to your 3 questions. And these are the conversation constructs that I'll use during the presentation of those 8 slides during the consult. Remembering, like we said, I want to think medically. I want to think medically. I need my team to think medically. I need the patient to think medically. I need the payment process to be medical. I want to close. I'm not going to close everybody. There's going to be exceptions. But if my target is high, my target's going to be 9 out of 10. And that office that I worked with was 22%, 2.2 out of 10. And with just a simple change, they got to 8 out of 10. Now, those are very easy patients to close. They knew they had sleep apnea. They were examined. They were diagnosed. They came in tested with a prescription. It's never going to get any easier than that. What a gift, 60 patients a month. It's a lot harder to close 9 out of 10 into a test. And then 9 out of 10 of those who got tested and have mild or moderate or failed or refused CPAP into an oral appliance. So now we've got 2 pieces of the funnel. First, a testing funnel. I see patients, I screen them. Some of them need to be tested. I want to close 9 out of 10 of them that should be tested into a test. Now, what comes back out of that test? Well, let's say that 8 out of those 9 come back with a positive. And Chad and I were just talking about this beforehand, how predictive the screening process and how predictive stop bang was. And Chad, you said you had some data that was internal about testing. Share that if you would mind.
Yeah, so my last review of our internal data, we provide interpretations. We have for, I think, going on 6 or 7 years now, and we've interpreted thousands of studies in this time. And a couple of years ago, we were at over 5,000. So I ran analysis at 5,000. I said, what does it show? And over 90, I'm going to use this number, but it's 95%, but we'll say at 90% of people who were tested with a mild or above diagnosis. And of those people that were tested, we saw that over 70% of them on average were actually in the mild to moderate category. The remaining 30% was split. Something like 17, I think, was severe, and 13 was, upper airway or snoring. So,
okay. So give me 100 patients that I think should be tested. And I can, let's say I can close 90% of them or 90 of those patients into a test. You're telling me that 90% of those are 81, maybe a little higher, but let's say 81, 82 of them come back with a positive result. And that 70% of those are 56 or 60, let's say 60 now of the total corpus of 100 are treatable with an oral appliance. So there's your funnel math. And that's something you should be tracking. Chad keeps an eye on the data and the statistics on their testing viability. In our practice and many other practices, I published a couple of papers where we looked at dose statistics, we looked at advancement statistics. We have this data, it's all available to us. How many patients did I screen? How many patients did I want to get tested? And then what can I change about my behaviors to improve the closure rate into that test or into that treatment? So those are really good, viable things. And these 8 slides should be one of those tools I think that would help. And they don't have to be my 8 slides. Don't hear that. Start with my 8 slides, make them your own by all means, change them around. If you decide you like them just the way they are, for God's sakes, they're yours. My gift. Chad's gift.
One more stat. Our gift. No, one more stat is 32.7% of your existing patient population need a sleep test. So that's an important stat. The industry range is 28 to 35. We have actual data from coaching clients. Some of you guys are on this call today. You know what I'm talking about. That shows that's our average over all of our clients, 32.
So a practice with 2,100 patients, not an unusual number at all, has 700 patients according to that data that need testing.
Yep.
And if 90% of them, 630 go through with the test, and 90% of those 600 go ahead and come back with a positive result.
Yes.
And even if half of them got an oral appliance, that would be 400 or 300. And if 300 got an oral appliance and you did 2 a week, it would take you 3 years to work through your own patient population.
Right. And most practices start off a little slower. So I will say this too, guys. We used to do this all the time. We've slowed down in recent years, but if you want to look at your funnel, starting with all those numbers, our coaches will go through your patient size, your average metrics, what goals you should be setting in your practice, and meet with you on what your program is doing and what little tweaks you can do. We'll throw in some information later, but if you want to know your numbers or what you should be looking at or how long you'll be busy with your existing patients, we'd be happy to do that with you. So anyways, Mark, keep on. Sean, I do see your question. Thank you for using the Q&A section. We'll get to that at the end here.
Okay. So let's look at these 8 slides. Let's look at these 8 steps if we think of them that way. My first slide that I start out with, and you can create your own slide, you can create your own definition, doesn't matter, is I say to the patient something like, in fact, let me back up. I sit down with the patient at a consult, face-to-face or online, small talk. I hear you referred to him by Dr. Wooters at Awaken to Sleep. Yeah, great guy. We've worked with him before. That's super. I don't have any patients to screen myself. They either come from another dentist who doesn't want to do sleep, or they come from sleep physicians. So he sent you over to see us, right? And I can see now the patient's already filled out the portal. We have an online portal that they can fill out in our EMR, so that we've got some medical records and information on them, health history. So I've got some indication that they've already had a sleep test. They haven't had a sleep test. They've got some complaints about health. I've got some information. So I make sure I recognize and acknowledge to them that I've read their chart and that I know something about them. And then I say, so how can we help? And I stop talking. And if the pause is really uncomfortable and long, I'll talk again, but I want them to talk. So how can we help? Well, Dr. Wooters sent me over said because I was snoring and he was going to make me a bite guard, but he said with snoring and a bite guard, it can actually hurt the airway. And so he thought I should get evaluated by you. Oh, excellent. So did he talk to you at all about obstructive sleep apnea or that you might be at risk for that? Yeah, he did mention something like, do you really know what obstructive sleep apnea is? And up pops this slide, right? So I explained to them, here's the following tidbits that I try to, and you'll find your own voice for this, but I'll say to them, so what happens is when any of us, every single human being lays down at night to go to bed, gravity works against us and the tongue has a tendency to fall back to the back of the throat and close off the airway. Now, it doesn't always close off the airway, and it doesn't close it off as much if we lay on our side. So when we lay on our back, it's usually worse, but look at how it wants to close off the airway. And here's the interesting thing. You know that little thing that hangs down to the back of your throat, the uvula? Yeah. And you know that thing that protects your air tube from getting food down it? It's called the epiglottis. Have you heard of it? Yeah, I have. Well, those two little things in every other mammal, except for humans, they overlap. So think about that. Look at this diagram. If that epiglottis and uvula overlap, when the tongue falls back, it'll hit them instead of close off the airways. So there's a little bit more protection in every other mammal except for us. Now, it's actually a lie. English bulldogs have the same structure. Other animals can snore, but it's not from airway closure. It's a nasal snoring. English bulldogs actually have the same anatomy. I don't know why they're the exception. No other mammal does. So it makes it easier for us as humans. And then plus, some people have large tongues. Some people have small jaws. In fact, most of us don't have room for our wisdom teeth because if you look back 300 or 400 or 500 years ago, our jaws were bigger and everybody had room for the wisdom teeth. So as our jaws are getting smaller and our tongues aren't, and especially if we get heavier, everything gets fat, including our tongue, it's easier for that tongue to fall back and those wet mucousy tissues to, and I actually make that sound and close off the airway. And that's obstructive sleep apnea. Now, that happens to everybody. It's worse if you drink. Everybody gets even more relaxed. It's worse when you're in really a stage of sleep called dream sleep or REM sleep. That's usually more of the second half of the night, but this happens to everybody. When it happens just a few times per hour, 0 to 5, there's no real health detriment to that. When it happens more, 5 to 15, we call that mild or stage 1 sleep apnea. When it happens 15 to 30, it's stage 2 disease. And if it happens north of 30 times, and we've seen people with 60, 80, 100 times, can you imagine? Twice a minute, some people will have where they stop breathing or they don't get enough air in and their blood oxygen drops down. And the problem with that is when you don't get enough air in, normally you would just go and take a breath, but you're sleeping. And normally if you were standing up and you didn't get enough oxygen to your brain, you would faint, but you're already laying down. So for these people, you'll see a sudden raise in their heart rate, a sudden raise in their blood pressure, and their body thinks they're pushing a car out of a snowbank, even though they're laying in bed sleeping. Can you imagine people that have heart attacks at night when they're sleeping? It's usually from obstructive sleep apnea. And it's because their body thinks they're pushing a car out of a snowbank. They're already laying down sleeping. How could you have a heart attack laying down and resting? In fact, if we have obstructive sleep apnea, these graphs show how much more sudden and premature the death is in those populations. The green line are people that don't have sleep apnea and their life expectancy over 20 years. Any and all cause of death, cardiovascular disease, motor vehicle accident, everything all lumped together. And then the purple, mild, the yellow, moderate, and the red, 53% of those patients survived, 47%. It's estimated that patients with obstructive sleep apnea live about 6.5 to 7.5 years less than people without obstructive sleep apnea. So by treating sleep apnea, we start to increase the chances for you and I to live longer if somebody does have sleep apnea. And there's so many different causes of death. In fact, you heard me talk about heart attacks. Well, it turns out that a person with obstructive sleep apnea is 23 times more likely than the average person to have a heart disease and have a heart attack at night while they're sleeping. The average person, if it's 1, overweight, hypertension, and smoking, don't even come close to obstructive sleep apnea, making that worse. They're also 4 times more likely to have a stroke and 5 times more likely to die of COVID if they get it. This is a very serious breathing disease. We did not used to know much about sleep, but today, honestly, we still don't know a lot about sleep, but we know enough to know that if we don't get a good night's sleep, it raises all kinds of hell with our physiology. We see increase in rates of dementia and Alzheimer's disease, worsening of several different chronic diseases. In fact, when you look at some of the most common chronic diseases, hypertension, diabetes, arrhythmias, stroke, congestive heart failure, depression, if you look at the center part of each one of those zones, that's the normal presentation of that disease in the population. And the bottom of each one of those is young people. And as you get towards the top, older people, and you can see most diseases get worse as we get older. Makes sense, right? But when you look at those dotted lines, the red dotted lines are for the women and the blue dotted lines are for the men. That's how many more people or how much worse that disease is in patients that have obstructive sleep apnea. Obstructive sleep apnea does not really cause any diseases by itself. Maybe some arrhythmias are caused by it, maybe drug-resistant hypertension, but for the most part, obstructive sleep apnea makes other diseases worse, causing premature death in those patients. No one ever has on their death certificate, this patient died of obstructive sleep apnea, but people like Antonin Scalia, Supreme Court Justice, Reggie White, the football player, died in their beds at night, having a heart attack, massive heart attack. Somebody say he died peacefully in sleep. Nobody dies peacefully in their sleep. They die with their body gasping for air because they have obstructive sleep apnea and they throw an emboli or a myocardial infarction and have a heart attack. Well, there's lots of things we can do to treat this. Some people are lucky enough that if they just sleep on their sides, the tongue doesn't fall back as much, especially in mild. Sometimes that'll help. Or if they lose weight, sometimes that'll help. So they make some things like this that looks like a fanny pack. They call it a slumber bump. You could wear a fanny pack with some crunched up material in there that keeps you off your back, or you could wear a backpack while you're sleeping. You could sew 3 tennis balls in the back of a shirt. Some people sleep in an upright position in a chair. You've heard about that. That's all those things are trying to put gravity back on your side. Oral appliance therapy, very easy to wear. Doesn't work all the time. Works about 90% of the time for mild and moderate cases, drops down to about 80% of the time. The actual data is 94 and 85, but I don't want to overpromise and underdeliver. I want to underpromise and overdeliver. So about 9 out of 10 patients are successfully treated with an oral appliance for mild and moderate. And even the severes that aren't successfully treated usually report they feel much better and are sleeping much better. And maybe we can move them from severe to mild sleep apnea. And if we can do that, sometimes that's still going to be considered a successful treatment. CPAP works 100% of the time, but hardly anybody can tolerate wearing it. If I gave 100 people a CPAP at the end of the year, half of them would be wearing it, and they'd be wearing it 4 or 5 hours a night, 5 nights out of the week. So that's not very good. I mentioned weight loss, sometimes oxygen. There are certain medications they're working on now. They're not as successful. There are a lot of different surgical procedures. Some people need their tonsils out because that helps close the airway off. You can see that there. Some people have that, the uvula hanging down so far, it's so floppy and swollen, it falls backwards and helps close the airway. So sometimes trimming and reshaping that and firming up that tissue helps firm up the airway. And then sometimes bringing the lower jaws forward. If somebody's got a really tiny jaw and a big tongue, sometimes surgery to move both the upper jaw and lower jaw forward can help. And then finally, you've heard of Inspire, no mask, no hose. Oh, they forgot to tell you about the scalpels, but they put a little pacemaker-like device in your chest, run a wire up through under your skin to your neck, and in the base of your tongue, they put it around a nerve in your tongue so that while you're sleeping, when the sensor feels like you're not breathing, it stimulates your tongue to jet forward to open your airway for you. And that's pretty effective about 70% of the time, 68 actually. And when patients get this, only about 3 out of 4 actually turn it on every night. So it works. It's really only a treatment that they try for people that are severe and can't wear a CPAP. And I think someday they're going to say it's for somebody that's severe and can't wear a CPAP and can't use an oral appliance, because those are just so much easier to use. This surgery is like $30, $40, sometimes $50,000. And so it's not easy to do. With CPAP therapy, most of the people that get one of these devices have a lot of trouble wearing it or wearing it all the night. A lot of people wear it the first half of the night, take it off and not wear it the second half of the night. They'll get up to go pee in the middle of the night and not put it back on. And it's the second half of the night where usually your sleep apnea is worse because you do more dreaming. You do more what we call rapid eye movement sleep the second half. But with oral appliances, we get really good compliance. So even though oral appliances don't work all the time, they have a very high success rate at being an effective therapy because patients will actually wear them. But I'm getting way ahead of myself. Before we really move into thinking about what kind of treatment would be right for you, whether or not you need to be treated, we've got to figure out whether or not you have sleep apnea. And the only way to tell whether or not you have sleep apnea is to do one of 2 different types of tests. And here I talk to them about polysomnography and a sleep lab test, and I talk about a home sleep test. Now, I'm stopping here and pretending I'm talking to you now instead of talking to the patient. In my mind, I've got to make a decision. Let's say the patient was screened in my office, or let's say the patient came in from a dental practice. I'm responsible for triaging this patient and either sending them to a sleep physician because they have a multitude of sleep issues, a very complex medical history, or some other reason that I don't think a home sleep test would be appropriate. Now, that's an important triage step. Home sleep testing primarily is only asking and answering one question. If you think the patient has sleep apnea and that's the problem, it asks and answers the question, does the patient have sleep apnea? It doesn't check for a lot of other conditions that are related to sleep, sleep irregularities, sleep cycling, sleep stages, restless leg, periodic limb movement, sleep latency program. There's none of those kinds of things are looked at really with home sleep testing. So if the patient doesn't have a really complex medical history, if they don't have a really complex sleep history, if we're just really asking and answering a question about sleep apnea, then I want to encourage them to consider a home sleep test instead of a referral to a sleep lab. So I show them the first type of test that can be done, and this is done for patients that really have complex medical histories, complex sleep histories, is in a sleep lab. And a lot of patients tell you right there, I could never do that. I can sleep lab. I know you couldn't. They wire up. They've got things all over. Sometimes it looks like a little cap you're wearing. But sometimes that's the right kind of test for patients to have. And it tests a lot of different things, but it is a little bit more challenging. Most patients do really well with, and I show them a home sleep test. And you could show in this picture whatever home sleep test you're using. That would be fine. And so, Chad can get you images of whatever sleep test he's using with you and make sure that you've got the right ones lined up. I've got several pictures of several different ones. When I lecture, this is a ResMed Apnea Link Air. I could use a Z machine. You could use Air. It doesn't matter. Whatever sleep test. If it's a 9 or something like that, it's really easy to show them. You just wrap it around your finger for Pete's sakes, or watch Pat 1. But the idea to say, and they look at this and they go, I think I could do that. Yeah, well, you wear this at night, and with the sleep testing we're doing, I say you wear this at night at home for a couple of nights. They mail it to you. You pick a date or 2 dates where you're going to wear it. They mail it to you. You wear it for a couple of nights. You mail it back while the physician is reading the data. When he gets that done, he'll send it to me. I'll give you a call and tell you what it said, and then you'll have a follow-up visit with the physician. And they go, well, that sounds easy. Sure does. So now remember our conversation. Do I have this? I don't know. We're gonna have to get you tested. That's what I'm closing right now. Is it serious? I hope I scared the hell out of them. Not scaring the hell out of them, but just making sure that they're aware this is not to be trifled with. And then, is there hope? Can you treat this? 90% is pretty good. Snore test, pretty good. So I'm trying to, remember what we said we're gonna do, I'm trying to answer some of their questions before they ask them. Okay, so home sleep test. So now I say to them, so what we really need to do is go ahead and get you tested. So let me go ahead and I'll turn to Denise and I'll say, let me go ahead and I'll have Denise order that up for you right now. Now, here's where we get our first ever, sometimes, conversation about money. I'm not lying to you. If you do not bring up money, it doesn't come up very often. This is a medically necessary. Patient wants to know, patient wants to get tested. But let's pretend that some of those patients, I don't know how many, because it doesn't happen often to us, say to me, well, wait a minute, how much does a sleep test cost? And I go, actually, it's covered under your medical insurance. That's my standard line. They're in a dental office. They know they have to pay for everything in a dental office. And so they're saying to me, I'm in a dental office. Is this going to cost me money? And are you selling me something? No, this is a sleep test. It's covered under your medical insurance. Okay. And if they say, well, I've got a big deductible and everything like that, there's no wrong model. You could dispense the sleep test yourself. Absolutely. You could refer to a physician every time. Absolutely. You could lose a sleep testing partner. Absolutely. No wrong answer there. It's whatever you're comfortable with in the conversation. And for me, I love kicking that off to a third party and saying, well, actually, they'll take care of that conversation with you and everything like that. But if you have a huge deductible, I can tell them it's around $300 for the sleep test. And then there's some fee for the office visit, for, the telemedicine visit. And they're like, oh, okay, it's not $3,000. It's not $100,000. They have no idea. Now I've closed them into a test. So these 8 slides give me the opportunity to walk a patient from unaware to aware to interested to trusting or believing in me to wanting to go ahead with treatment or therapy and get their sleep test. It's really, if you will, the opportunity to move them from a decision that they make with their head to a decision that they make with their heart. And that's important. So it's moving them from their head logic decision to emotionally this conscious, trusting, believing in you kind of thinking. There's a book called 18 Inches, which talks about actually a faith journey, but you could think of it as a journey that a patient goes through from head to heart. And now they can make a decision, right? But it's not done there. It has to travel another 18 inches to their wallet. Because just because they decide they want to get something done, the heart, till they actually reach down into their wallet and make their co-payment or use their insurance card or something like that, there isn't really that closure of an actual sale. Sometimes in dentistry, we convince the patient in the back in the treatment room, and they say yes to everything. Then they lose their brain by the time they walk up to the front desk, and they never schedule for the treatment. So once they pull out the wallet, we're done, right? Nope. I would argue that it doesn't feel right until that patient has traveled 18 more inches to their knees, where they drop down on a knee and give thanks for what you've done. And I'm not expecting them to actually drop down on a knee, but when you treat a patient and they text you back and say, man, I'm sleeping better, I'm not snoring, my dog's back in bed, my wife's back in bed, this is great. That feels good. You feel that appreciation. And it's still not done there. It's got to still travel another 18 inches to their feet, because that patient should become a missionary for your practice and tell their friends, their neighbors, other people that are on CPAPs, that you got to come see this guy. It's been incredible. So think of this 18-inch journey from head to heart, heart to wallet, wallet to knees, knees to feet, as a journey that the patient can take in your practice as you're treating for sleep. So Chad, those are my 8 steps to yes. You've got my email there, so you're welcome to email me for any other information, questions, anything else you need. You know, I'm always available for that. And then I'm going to leave you your slides here. Do you want your slides up next?
Yeah, real quick. One comment, just because we
Sure.
have a lot of, I see a lot of our coaching clients on here too. And
Good.
a lot of practices start on fee for service.
Sure.
And that's just to give perspective, because Mark gave a number. He said roughly $300, which is the average fee for a shipping test. One number, I don't know if you know this, I'm sure you do, Mark, but the average cost for a home sleep test administered by a sleep center or a medical practice, after the patient's insurance is considered, is somewhere between $600 and $800. That's their cash fee. So whether you're using a third party to ship that, whether you're using your own home sleep test, most of our clients are charging $140 to $250.
Beautiful.
It's a steal.
Mhm.
When the money comes up, it's the best deal they're going to get. So just a encouragement for those that are starting fee for service. So
Love that. And I think starting fee for service, we've talked about this many times. I love this idea of starting fee for service, because you don't have a lot of these other unusual costs or reoccurring costs while you're doing 1 or 2 devices on yourself, your friends, your family.
Yep.
I'm sure I'm not going to collect a full fee from this ENT and his wife. If insurance pays something, that's going to be great. If not, he's going to pay the laboratory fee. So that's wonderful. But so when you're getting started, the first 3, 4, 5, 6 months, you're worried about just walking through the process, getting used to doing this. I think that's fee for service. And don't get me wrong, you always want the best closure rate you can get, but you're okay if not everybody says yes. You're finding your way. Once you say, hey, I've got a little pattern here and I'm doing 3 or 4 devices a month, well, now you need a software partner. Now you need a billing partner. Now you need other things, and you've got those things available as well. So that's great.
Yeah.
Appreciate that.
If you don't mind going to the next slide, Mark. One, if you guys want, whether it's us breaking down your funnel, us looking at your process. I just talked to a doctor who's been trying to on and off for 5 years to try and get sleep going, and the little things, making it easy for patients to say yes to the test, all the stuff that Mark's talking about. We talked about some of those different, it was one of our coaches' approach to it, but making it easy and connecting with that patient's pain, treating it like a medical practice. This is the next step every time. Makes it easy. And if you want to connect about your office, you're welcome to do that. This is a free call. It's for 30 minutes. It's available for us to connect with you. And then one last slide for us, or I guess, sorry, 2 more. We have, if you want to learn the soft skills, what Dr. Mark is talking about, in our 1-day course for you and your team, we're going to go through A to Z, the entire workflow from screening to treatments, focusing on soft skills. And whether it's your first time, you want to go from 0 to level 1, or you want to go from level 4 to level 5, this course is jam-packed, and it is fast-paced and fun. You have to be on camera, though, because we do role-playing, we do group breakouts. It's a blast. So we encourage you. This is discounted. It is next Friday. We were going to do this Friday, but Mark and I got to go to the NADSM. So, we can't do this weekend, but next weekend, go to the website with that link and register for you and your team. And Mark, you want to go to the next slide just so we've got those QR codes for everyone.
You got it.
And while we wrap up, I do want to say this. We're going to stay around for a few minutes to answer your questions. It is 6 o'clock though. So our team is going to put the CE link in the chat for those that got to go. But we'd like to actually answer a couple questions we've got in the question and answer section. Are you good, Mark? Or is there anything else you want to throw?
Absolutely. I am
Okay.
perfectly good. I've got the first question queued up.
Cool.
Sean asked, when do I recommend a titration sleep test to determine efficacy of the appliance? Boy, that's a wrestling match all the time. So when the patient thinks they're in the right position, then and there's different styles. Let me back up. When the patient goes home, then there's a titration sequence. For me, I let the patient advance themselves. I give them a schedule every 5 days, millimeter forward, advancing the arches. I use a lot of Evo. And so that's a really easy titration schedule for them to follow. And then I say to them, when you find a spot that you think you sleep the best, and if you go forward from one spot to the next and you don't like it as well, come back. When you say, I'm sleeping well here, my jaws feel good here, this is comfortable, high five, I have them come into the office then, and they pick up a pulse oximeter. They wear the pulse oximeter for 2 nights. I upload the data, I read it, and I say, that's good data, go get your sleep test. Or I say, that's bad data, even though that's a comfortable place for you, the data doesn't match how well you're sleeping, let's try 1 millimeter forward. And so that gives me and it's me trying to get better results with my physicians and impress them so that they get a better follow-up sleep test, because nothing pisses them off or me or the patient more than getting a sleep test and going, you should go back on CPAP. And you say, well, no, wait a minute, we can advance him some more. And the physicians I work with are great. So they say, Mark's got to titrate you some more. But then they're like, I got to pay for another $300 test or a $600 test, or that, and that's what Chad said, $600, $800. Holy crap. And especially a lot of insurances can say, well, we're going to pay for a diagnostic test and we'll pay for an efficacy test. But after that, you're on your own, buddy. And so now the meter's running. And so patients don't like to go back. Now, having said that, I would love to tell you that, and I do close about 90% of the patients into tests, and we close just about everybody, 90% at least, into devices that need them. We're very, very effective at that with our conversations. I'm terrible at getting these patients to do their follow-up testing. I would bet you that 50% of my patients get the pulse oximeter data and they go, listen, I'm feeling good, I'm sleeping good, Mark says the oxygen was good. And I see them 6 months later and I go, hey, I didn't get a test from your physician. Did you go back and see them? Nah, I didn't. Why not? Well, I'm feeling so good. And so I'm like, well, we don't really know. Well, you said the oxygen data was good, but I told you that's not a sleep test. That's just one piece of information. That's like looking at your heart rate, but I don't have your cholesterol data. I don't have the full picture. Oh, okay. And then they don't go again because they feel so much better. So I got to be honest with you, probably half our patients actually end up getting, I do have the data actually, and it is around 50%. It's actually just slightly below. 50% of the patients get the efficacy test.
So if I could give you some antagonistic data, just to poke you a little bit, we do have with many clients who own and operate their own equipment, they're running full on. Yeah. And your model is so different, but we have, it's $6 or $12 to run an efficacy test. And we have if you want to clean up the data, we have an AI titration service. It's like $20. So $25 out the door costs. You include that in your treatment plan and you don't give your patient, again, different model. You're doing the pulse oximeters, which are working. It's just not the full on test.
Right.
It's similar. It's a watch, right?
Yeah.
But we see a lot of practices when the patients come in, they're like, oh yeah, you're just going to take it home. It's included. Do it. And that's
what sleep test are you using mostly?
Our 2 primaries right now are Alsnet ones and ResMeds. Those are the 2 we see most frequently.
Test.
But we got Bravogs, we got Knox. So.
I could send everybody home with a test, and my consumable cost is $12. I know that. So my consumable test will be $12. But now, if the data is good, then I've got to send it over to my sleep physician and say, hey, I ran an efficacy test. The data was good. Why don't you read this and charge them? Mm-hmm. And if I'm sending them back to their dentist, I also got to send them back to either a telemed or something to get tested. So I still got to close that loop. So when I think of an efficacy test, I'm thinking of they are treated and the physician has interpreted that test.
Yeah. We also do efficacy interps. So yeah. So if you have any questions there, it's a great tool. On that, Dr. Moser is asking, what pulse ox do you use?
So I use the CMI Health. There's lots of different ones out there. What's this other one I've got down here in the drawer? Let me look at this one right here. This is Oxynite. Oxynite, CMI Health. So here's one of the CMI Health ones. They're high-res pulse oximeters. What I like about them is I like that one the best, and they don't make that model anymore because there's no buttons to touch. You tell the patient when you put it on, it turns on. So don't put it on till you're going to sleep. So put it on, it turns on. When you take it off, it turns off. No buttons to push. So I use those for all my seniors. And if I've got somebody your age, I can actually trust you to push a couple of buttons on it and we'll get good data. And the oxynites. But these things they're very inexpensive. They're 125, 150, 190 bucks. And they're a good quick check. It's not a sleep test, but it's a good quick check. And like you said, from a consumable standpoint, if you do use a full sleep test like the Alice or the ResMed apnea link, it's 10 bucks, 12 bucks. It's all it can cost you. I see a good one here. What's the best approach to connect with sleep physicians for referrals? I would say the most effective that I've had is when I end up with a patient who already has a sleep physician and I'm going to treat them, and then I've got to talk to them and they've got to talk to me. They don't have any choice. And then we have a really good result. That's the best way for me that I've connected with sleep physicians. Even with that though, I've done a few lunch and learns. You knock on a lot more doors than you get in. You do a few more lunch and learns, you get referrals. I'm not looking to grow because I have a full-time responsibility with Prosomnus, so I can't get any busier. I just don't have any more time. But I would say go in there with data, information, and facts. Physicians hate gunky appliances. They hate patient complaints about appliances. They hate side effects. So going in with science instead of going in with a medical model instead of a dental model. Data, studies, that's very, very, very positive.
I'll say this too. Our company was founded by someone who used to build, CPAP and home sleep test referral companies. We actually have what's called an MD marketing kit, and we have a pathway that you can follow for that piece. So if that is something you're interested, let us know. Again, talking to us is completely free. We're happy to give you some free tips. We usually give 3 to 5 tips on how to do whatever you're trying to accomplish. So
sure. Chuck is asking about the Night Owl. It's not a pulse ox. The Night Owl is not a pulse ox. It is an HST. I actually do think of it a little bit as a pulse ox on steroids, right? Because there's a lot of sleep physicians and some insurance companies that still won't look at Night Owl data and consider it the same as they would some of the other sleep tests. So I like it, but it's 90 bucks. And so if it's 90 bucks and I can use it 14 times with the patient over 2 or 3 years, and I do have about 5 or 6 of those, but I can assign that to a patient who lives far away. I did that with a patient who was in Rhode Island that flew in to see me. I've done it with a patient who was up in northern Michigan who came down to see me because it made sense. And I told them that they had choices of driving back and forth, or I could charge them $100 for this extra service, and they love that idea. So I charged the cash fee for them. And if they're Medicare, they've got to sign an ABN for that if you're doing it as well. What do you think
the only thing on the Night Owl is it's cost-wise from efficacy testing and titration testing is you're looking at those are in the $100 range per unit. So they can do 7 nights of testing. So just
14.
Okay. So you can do the 14 nights of testing with that. So the cost ends up being comparable, but you are looking at a $100 expense out the door versus like a
absolutely
or something.
And it's a one patient use. So it's not like it's $100 and you get to use it over and over again. It's $100 and you assign it to a patient. Juanita wants to know what I think about Fitbit. I wore a Fitbit for years. I wear an Apple Watch now. I loved my Fitbit. It really broke my heart to give up my Fitbit and move to the Apple Watch, but my wife finally convinced me, and so I made the change. I really like Fitbit. It's great data. Not FDA approved for diagnostic, not FDA approved for what we're doing. but it's a great tool for patients, and so are lots of other rings and things that are out there. And for a patient to get over-the-counter information to look at and manage and understand trends about their sleep. But if we were to think for a second, we're going to walk into a physician's office and show them Fitbit or Apple Watch data and talk about the sleep staging, they will laugh you out of town. So
cool. Real quick, Hope asks, are you guys getting a PDF of the slides? We are sending you Mark's 8 slides later tonight. If you do not get them for any reason and you were here, please check your spam, because we have links in our emails. I don't know, Gmail and whatever, they're weird. When you put a link to a download, it happens that it doesn't like you sometimes. So check your spam. Check that 2 hours after our conclusion tonight or tomorrow morning. And if you don't get it, feel free to email in. We'll send you the link.
And you'll actually send them the PowerPoint, right?
Yeah. Yep.
Yeah,
The
good,
actual
good.
PowerPoint, not
That way
just
they can
PDF.
modify it however they want.
Yep.
Perfect. Perfect. Yeah, good.
All right. Wow.
Let's see. Is this the appropriate place to ask for links to the studies you're referencing? Yeah, I've got a lot of studies. If you write me and talk about what kinds of information studies you have, my narrow focus on that is probably going to be with precision oral appliances. And so the precision oral appliances have spectacularly higher efficacy than a lot of the non-precision or custom oral appliances. And so, and you can't say, hey, this applies to these devices as well. It's very specific to devices. In fact, the precision device that I use a lot of, the Evo from Prosomnus, will probably be the first oral appliance to ever get a severe clearance indication from the FDA. That's how high the efficacy is. It's pretty cool.
If you want the other studies that are not just precision related, I know, Mark, you have a few, but like that cohort study he mentioned, I've got a copy of that.
Oh yeah, for sure. That
So,
stuff. Yeah.
Yeah, we're available as a resource.
HRQ paper, all that stuff that's all out there. That's great stuff.
Yeah.
There's an interesting question here. I'm not sure I fully understand. What's the efficacy for patients with micronathia not willing to go for surgery and treatment with just an oral appliance? I have no idea. No idea. The efficacy for patients with micronathia not willing to go for surgery, just with an oral appliance. We treat patients with smaller jaws, and I don't know how small something has to be considered micronathic, but I'll tell you what we see is most of the improvement that we get using oral appliances is because of the mechanical ability to advance the mandible forward, opening the airway in the back. Got that? That has a lot less to do with the size of the jaw. Now, if I can put a smaller device in their mouth, that allows the tongue to come forward with the jaw more easily than a bulky device. So smaller precision devices allow for a lot more tongue space. That said, patients with smaller ranges of motion are more difficult for us to treat because I don't have as many millimeters to pull them forward. And if I need 2 or 3 or 4 millimeters or 5 millimeters of advancement to pull that tongue off the wet mucousy substance, and they only have 7 or 8 millimeters of range, they might not be able to tolerate 5 or 6 into a 7 millimeter range. And so it's a really challenging question to answer. Would you not treat them because of that? No, I'd still try to treat them, but I might say, man, you got a really big tongue, you got a really small jaw, or you're really fat, or I wouldn't say that, your BMI is really high, or you don't have much range, you have a really tall jaw. Those would be things that I would look at and say to the patient that probably works against us.
Mm-hmm.
But just like you would look at any other kind of treatment, I'd still try that med, I'd still try that drug, I'd still try that treatment because it still might work. But the primary thing we're looking for is a mechanical advancement. Now, we also know that we might have an effect on arousal threshold, loop gain. We're getting into deeper discussions now, and that the precision devices have an anatomical form. And if we don't go as far forward, we don't stimulate that reflex action, that paradoxical non-responder that we see. That's exciting stuff, because maybe when we're seeing 90, 94% instead of 65, 75% success, some of that is mechanical. We know that. Smaller devices, better precision, better bite relationship, all day. But some of that might be these non-anatomic factors. So that's harder to measure.
Yeah. One thing I know, you have your tiny appliance that you use that has the micro adjustments. So yeah, it's cool tech. On appliances, we have Pete asked, Dream Tap, first impression, yay or nay?
So Dream Tap is a bulky device in the anterior. And so I'm not a fan of the tap, but I use it on a patient that only has upper and lower anterior teeth, because I can't put an Evo with posts in the posterior range in the back of the mouth. So there's a time and a place for different kinds of devices. Yes, somebody who works full-time for Prosomnus said they use other devices. There's patients that freak out about their veneers and don't want acrylic or even the special Evo material on their veneers, and they want something really flimsy. And so then we look at a printed nylon material. But usually, I mean, 39 times out of 40, I can find a device within the Prosomnus family that's precision, and I'd rather use that because we get better efficacy. I would try to make my decision tree based on what appliance I use, based on what devices have the best efficacy, so I can get better outcomes, rather than which one is pink or which one is blue or which one did the patient think they liked. Our responsibility is to chase better outcomes for the patients.
Yeah. Abby asked, do we recommend titration test for mild to moderate patients below with an AHI of 5 and a higher RDI?
So when we ask the recommendation questions, it's who would recommend, and if it's Chad and I would want to get paid by the insurance company, and insurance companies chase AHI today. It's probably the wrong metric. RDI, ODI, probably better metrics. Hypoxic burden, a far superior metric, because none of the ODIs, RDIs, or AHIs are predictors of cardiovascular events or all-cause mortality. But in the literature, delta heart rate and hypoxic burden are. And so we're going to see a shift to different metrics, and AHI is going to go away. But today, you're not going to get reimbursed from an insurance company. So now you're down to a cash patient, and we have those conversations occasionally. Patients' AHI is 4.9. You know, their RDI is high. Hardly ever will insurance company allow you to treat them and pay for it. They'll allow you to treat them, but they're not going to pay for it. And so now it's a conversation with the patient. What do you want? And we definitely have those conversations all the time.
If your AHI is high, we call it closing the liability loop. Even if the AHI is 5.1, showing that you did that extra test and the physician saying this was effective treatment, it's nice to have that, so that if it comes down the road, you're good to go. Real quick, I do want to say we got 3 questions. I think Mark is open to answering them. They are super clinical and definitely not relevant to the topic tonight. So we're going to answer these, but
then we're done.
cut off
And then we're done.
Jennifer's. If you've got treatment planning questions, feel free to jump in. Otherwise, I'm going to point you back to that coaching call. We have clinical coaches, dental assistants, and doctors who've done this for years. In fact, one of our coaches has been doing dental sleep medicine for over 15 years as an assistant. And so we've got the team to support these questions, but we want to be on topic for tonight. So Carol asks,
I'll fire these off. What type of exercises or AM positioning? I use milled morning occlusal guides. I give the patient 2 of them. And then I show them all the things they need to get at the bite bag, explain to them how and why. And we're really proficient at not losing any bites. If they lose one of those, they're supposed to call and order another one, and I'll charge them for that. I used to use the thermocryl beads, but I just got lazy. And for $50, I can get 2 of these mogs, and so I like that. Any plans for edentulous patients? Nope, that's heroics. I don't do it. I tell them we can't. I know people that have. Good friend of mine, John Corolla, brags about 1 or 2 cases he does a year, edentulous. High five for him. I'm not going there. That is heroics, very chancy, low probability of success. Final question, when would you use posterior excluders for appliance? The answer is never. It would open the vertical dimension, which I do not want to do. If I were going to use a discluder, it would be in the anterior for a bruxing patient who had broken a post. And if a patient had broken a post, maybe I would widen their corridor a couple of millimeters. We can prescribe that. Maybe I put a 2 millimeter anterior excluder in, but I don't think I can't think of a reason that I'd ever use a posterior excluder on an appliance. So there you go. Those are easy. Those are fast.
And a lot of patients don't brux after you treat their apnea anymore. At
that
least
is
I
correct.
don't.
So people ask me, do you put an anterior excluder on for bruxers? I go, nope. Do you widen your corridor? Nope. Do you use a herps? Because I go, nope, because most of them don't do that. And give me 100 bruxers and 1 or 2 of them will break a device. Okay, so I'm not gonna go in there and make everybody with these funky little design things just because 1 out of 100 or 2 out of 100 will. Does their muscle activity and tension decreases, the airway stays open? Absolutely, James, 100%. What do you use to take a bite? George gauge. Okay, we answered 2 more questions than we were supposed to.
Okay, thank you. Hey guys, look, the CE's in the chat there. After we close out the meeting, you're going to be sent over to the CE link. We are so grateful that you joined us tonight, Mark. We are so grateful.
I'm so grateful that many people wanted to hear me talk about something like this. Awesome. Thank you for the opportunity. Appreciate it.
We are emailing the actual PowerPoint. I know a lot of people don't do that. We're doing that. The PowerPoint will be in your inbox later tonight, and the recording, Brooke, one of our amazing support staff, already put that link in the chat. It'll be on our website. It'll be in your email as well. That page is up. The recording isn't up because we can't post the recording until we close the meeting. So that is our next step. So folks,
shout out to
thank you.
Earl from
Yep.
Southfield, Michigan. How you doing? I saw that he's in here. That's kind of cool.
Abby said she's always a Murph Doggy Dog webinar attendee. We also had someone from like really far away. I missed it, but they won the competition. Nova Scotia.
Nova Scotia. Woo.
Yeah, getting
And
international.
hello, Betty,
here.
my friend from the Cleveland Clinic down there. That's cool. Gary Sussman. There's a lot of good people and a lot of people I know. Yeah, for sure.
All right, guys. Well, Mark, thank you. Have a wonderful night, everyone. And we will see you on our next webinar.
All right. Thanks ever so much.